Good morning, good afternoon, good evening to all the viewers from different parts of the world. We are connecting after almost 2 months now. Hope you all had a great New Year celebration and wish you everyone a fantastic 2023. Welcome to this WSPOS Independent Medical Education webinar series. We had the 2 myopia webinars in November. This is the update for the question and answer sessions. This IME support is provided by our gold level supporter, Luxottica, silver level supporter, Hoya, and of course, our bronze level supporter, Cooper Vision. WSPOS Education Forum is a resource for all the evidence-based education programming. It features symposia, it features webinars like the one we did last November, video interviews, we have different podcasts and an e-learning and supplements. This is a great resource for evidence-based education and programming, and that's the address. You all can go there and watch all the educational materials, including the previous myopia webinars. Today's agenda is a follow-up program to our previous WSPOS IME symposium, the comprehensive update on myopia management held on November 19th and 20th of 2022. We are going to have addressing the most important and the relevant questions we have received after both the webinars. We have fantastic panel today. I'm joined by my co-moderator, Professor Ken Nischel, who is a professor of ophthalmology and vice chair of quality and director of pediatric ophthalmology, strabismus and adult ocular motility and pediatric program development at the University School of Medicine at Pittsburgh. Over to you, Ken.
Thank you. Thank you so much, Ramesh. Welcome, everybody. The questions that we got for the last 2 webinars were amazing. There was an overwhelming pouring out of questions and queries, so we're going to try and address those today. And we're very lucky to have an amazing panel, which I'm going to introduce you to. Of course, Ramesh Kekanuya is my co-moderator. Ramesh is the head of the Pediatric Ophthalmology and Strabismus Unit at LV Prasad Eye Institute. He's also director of the Center of Technology Innovation and the network director for LV Prasad. So great to have him on board. Well, who doesn't know our panelists? Ian Morgan, Professor Ian Morgan, is at the Australian National University in Canberra, and he's at the State Key Laboratory of Ophthalmology, Songjian Ophthalmic Center, Guangzhou, China. Mark Bullimore is an adjunct professor at the University of Houston and College of Optometry in the USA. A great, who doesn't know Mark? And then again, if Cheryl know, is consultant ophthalmologist and medical director, adult and child eye clinic at the Eye Surgery Center at the National University Hospital. And she's an adjunct assistant professor there at the NUS School of Medicine in Singapore. Welcome. And Professor Carly Lam, Center for Myopia Research, School of Optometry, Hong Kong Polytechnic University, Hong Kong, and the Center for Eye and Vision Research in Hong Kong. Last but not least, Xiaowei Liao, one of the executive members of the WSPOS and at the Adult and Pediatric Eye Specialists Group, Mount Elizabeth Medical Center in Singapore. Thank you very much, everybody, for coming on. So we have some audience response questions. If you could respond to these, please. Question number 1, where do you practice? Europe, Africa, Middle East, Asia Pacific, India subcontinent, North America, South America, Australia, New Zealand. I have to say, by the way, it's in the middle of the night for Professor Ian Morgan. Thank you so much, Ian, for being with us, or anywhere else. We'll get the responses. You'll be able to see the responses. We're going to move on for the sake of time. How many pediatric, under the age of 18, How many pediatric myopic patients do you see in your practice each month? So if you could answer that, and then we'll try and feed that back to you during our talk. And on that note, we're going to move on to the important part of the webinar. There are a lot of questions. So what we're going to do is going to ask one panelist to answer a question, and then the other panelists can chime in. And I'm going to kick off with the first one. Is myopia more genetic or environmental? More specifically, do children of East and Southeast Asian origin living in Europe and USA have a higher risk of developing myopia? And should we treat different demographics differently? Okay, I'm going to take that one first. In my opinion, in my experience, having worked in the UK and having worked in the United States, I don't think that there's a difference in what the origin. What there is a difference in is if the child has myopic parents. The child has myopic parents, I'm much more likely to be aggressive in treatment and treat earlier, but I haven't found that East or Southeast Asian heritage in itself makes me treat the child differently. So I'm going to open that up. I know that Mark Bullimore just did an editorial on this, but anybody got anything different to say, or do people agree?
Look, I think the crucial factor that you need to look at, it's not so much ethnic origin, but it's the kids' engagement in two sorts of activities. One, intense education, and two, having an indoor or an outdoor lifestyle. They're the things you really need to understand. Now, because of world history, there's some correlation between ethnic background and those sorts of behaviours. But the really important thing is, for example, to know that if you're dealing with a very young child, is the parent going to push them into a really accelerated educational stream? The actual impact of genetics, my reading of the literature is that in any population, there's 1 to 2% of kids who become myopic for purely genetic reasons. They have mutations of large effect size. You'll certainly see them in your practices. But
Ian, I'm gonna
everyone else needs
Yeah,
environmental input to become
so
myopic.
I'm going to move to Carly, Xiaowei, and Cheryl. What is your take on it before we go to Mark?
So I'm first, right? Okay, yeah. I think, yes, as Ian mentioned, so it is always an interplay between genetic and environment, and the lifestyle is certainly a very important factor. But I also like to bring in the word susceptibility. So among the Chinese Asian origin, they are more susceptible. So even though the same environment, same signal to a Chinese Asians, they probably react much more progressively than the Caucasians. That's from what I have seen in the last 20, 30 years of literatures. But I also see Chinese being ametropic, and they are farmers, fishermen. But if they are exposed to like higher education demand, competitions, parents' influence, then they will go towards becoming myopic. So that's my view.
Okay, Xiaowei or Cheryl?
Yeah, I agree with Carly as well. I think that's what I've been seeing as well.
But so I'm going to bring Mark into this and Ramesh, because do you think that it's because because most of these children will have myopic parents? So do you see children who don't have myopic parents who now are myopic, and as to Ian's point of view, it's the environmental, that they're intensely studying, whereas their parents perhaps didn't?
Yeah, definitely. I mean, in Singapore, our prevalence is so high anyway. So we do have a lot of patients who do not have myopic parents too. So it's the whole environment as well.
Ramesh?
If I can add, we in India don't see so many myopic parents, but I'm not saying it's zero. But what we see is between the urban and rural. When we have a very, very high prevalence in the urban area, But when we go to our own centers in the rural areas, we hardly see any myopic patients. This is the great divide what we see here.
So, okay, so let me, Mark, you have the final word on this before we move on.
The only thing I would add is, and you kindly referred to a recent editorial, I don't think we should be treating myopic children any differently, regardless of where they are in the world. So,
I think that's a great point. Okay, so I'm going to move on. When do you advise genetic testing in myopic children? And I'm going to take that one as well. So I think if your myopia is bigger than your age, then you need to worry about something else going on. You know, if I see a 3-year-old who's -6, -7, I am really going to dig deep to make sure they haven't got a tinge of blue sclera, that they, or any blue sclera, that they don't have any signs of familial exudative vitreoretinopathy, and the wide field imaging techniques that we have allow us to look out there. So that's when I do that. And obviously, if they have any ancillary signs, nystagmus, nyctalopia, you're going to worry about genetics. Anybody got anything else to add to that particular question? Would everybody agree?
Yep.
Okay, good. Let's move on then. When do you start interventions for myopia? And I'm gonna put this to Xiaowei, but everybody will get a chance to give their point of view, because this is important. And we're going to come back to it later as well when we talk about pre-myopia. At what age should we start treatment? Is there something as too young or too old? Xiaowei?
I think if the child is progressive, having progressive myopia, we should start treating. Since it's, I mean, like even the LAM study, the Singapore, the ATOM study started in the primary school children, and the LAM studies once were younger, in even the kindergarten kids. So I really don't think there's nothing that young. I would say from kindergarten onwards, you can treat. And I don't really have a specific age in mind in that sense, as long as they're progressing. And there's nothing at too old, as long as they're still progressing. So if I see an older child, but they're progressing, I would also start treatment in that sense. Yeah.
I know this is controversial, so let's go right around the panel quickly. Ramesh?
Yeah, I think if the parents are myopic, I know that there is fast progression. I know that there is because myopia sometimes, if it is happening to young patients, they come with 0.75 at 3 years of age, I may not start unless the parents are highly myopic, both the parents. If they are not, having a very high myopia at a 3-year-old is pretty rare. So I would take it as a case-to-case basis.
Okay, Mark? Fast progression, by the way.
Depends on the race and the age.
Wait a minute. You said that we shouldn't treat children differently depending on race. Now you're saying it depends on the race.
No. Well, the reason I can say that is because I don't think you should wait to see progression before you start treating. If you've got a myopic child, okay, the myopia has developed recently, 99%, maybe at worst 95% of those children are going to progress. They're never going to progress as fast as they are in that first year. So start treatment right away. Don't wait until you see progression.
Okay.
Well, can I just add in that? So for me, progression means that they gave a history. That means they could be the first time they're seeing me, but they gave a history that 6 months ago the school check was okay. Now when they see me, that is, to me, it's progression. So I think that's the definition. That means that it's a first visit with me, but it's documented that 6 months ago was okay, and now he can't. That's blurring. That it's myopia. So that to me is progression. So maybe did you think that I had to wait like 2 visits? No, so I don't know what's progression.
For the sake of time, Cheryl, Carly, anything to add?
So for me, intervention does not may not mean like pharmacological treatment. It can mean like even lifestyle modification. So I think once they start being myopic, we should put in interventions to educate the parents. But for treatment with regards to pharmacological treatment or even optical management, I think that we can discuss with the parents when we should actually start.
Okay, Carly, anything to add?
Yeah, exactly. I think communication with the parents, with a lot of factors, whether they have text in all of them, would be a good start.
Okay, so we're gonna, the last two questions actually get covered in other questions later on. So I'm going to ask Ramesh now to take over.
Thanks, Ken. So this segment is on behavioral modification. I have two questions, this probably to Ian Morgan. On an average, how many hours per day should the children spend outdoors? How much is enough?
Okay, well, the simple answer is the general recommendation is about 2 hours per day outdoors. I think the epidemiological evidence is that if you can push that up a bit, up 3 hours is better, 4 hours and probably virtually going to block the appearance of myopia. In China, there was a great deal of interest. One primary school in China in the last round of national testing had no myopia at the primary school level. A lot of excitement about this. What's unique about that school? It's a boarding school, and the boarding school gets kids outdoors for 3 hours a day. No myopia. So I think that points to the potential for getting to that 2 hours and going a little bit higher.
When you say 2 hours, Ian, I just had a related question. Do you think the timing is important? It should be noon or early morning? Because a lot of our middle-aged patients, they ask this question, they can't even go out. Do you have any kind of answer for that, or is there any evidence?
I don't think there's any real evidence, certainly from human studies. The studies on animals are starting to suggest reasonably consistently that there's something about doing it in the afternoon, evening, rather than earlier in the day. But I don't think that's yet confirmed in any human study.
Sure. Anybody else has any comments?
I actually have a question, Ramesh. I mean, when it's -10, -20, -30, where I am in North America at the moment, the kids are not necessarily going to be going outside, but if they sit by the window rather than sit indoors where there's no natural light, does that make a difference, Ian? Is that better than nothing?
It's probably better than nothing, but if you take a light meter and measure light intensity, unless you're really with your face up against the glass, there's not a big difference inside. It's much better to get outside. Let me just remind you of Norwegian child rearing practices. They take the little ones swaddled up outdoors in midwinter for a couple of hours, so they can get the available life. That's obviously a cultural adaptation to an environment where, without doing that, you do have problems with visual development.
All right, let's move on to the next question. This is a question I think 100% of the parents will ask, and close to 90% of the parents feel guilt about it. So how much screen time is too much? Ian, you want to go?
I'm happy to. How much screen time is too much? It's when the amount of time that stops a child from getting enough time outdoors. There's no evidence at the moment that reading, using a screen is worse than a book, maybe a bit more addictive, but physiologically, there's no difference. But the really crucial point comes when obsession with computers and smartphones stops the kid from getting outdoors.
So you mean to say that the books or tablets does not matter in terms of duration? It's that addiction. If they carry a tablet, they will go on and on. That's what is more concerning than the time.
Well, yeah, obviously, but that also causes the problem with time. As I said, I think there would be no particular issue from the perspective of myopia. There might be in more general behavioural terms, but from the perspective of myopia, as long as kids are getting outdoors enough to slow down the development of myopia, that's the sort of time that parents need to start cracking down.
Yeah, I have
Yes.
something to add.
Connie.
Yeah.
Yep.
I think in the old times when we don't really have all these gadgets, so reading near work has been used to relate to myopia development. And at that time, we already found that like even 20 minutes of very close reading can create pseudomyopia. But there have been no studies confirming whether this pseudomyopia will become permanent, and we don't know how this process developed further. But definitely 20 minutes of very close reading developed pseudomyopia. And pseudomyopia is a kind of hyperopic defocus. So I think if we are going to implement education on screen time, is to ask the children to have breaks. So they have use it for a while and then they break away, look at something far away, do something else, and then come back to it.
Yeah.
Could I just make a comment briefly on that? One of the recommendations around is 20 minutes, 20-second break. Not enough. Yeah. The animal studies are absolutely clear on this. Just sitting reading, 20 seconds, back down again. Useless.
So that's why I didn't use that.
No, I know, but this is something that's commonly recommended around the world. The break has to be sufficient for kids to get outdoors.
So Ramesh, I just wanted to interrupt here. I just want to say, you know, Mark and I have had this discussion, and I think it's important to know that while there's a suspicion that increased digital time, screen time has an effect on myopia, one of the best meta-analysis published in Digital Lancet Health, which actually Mark pointed out to me, has come up with the conclusion that it might, but that the evidence is not strong enough. And as Ian was saying, it's more to do with how the behavior is modified rather than the causal effect of actually using a digital screen. Mark?
I kind of agree with Ian on this issue. And I would point out two things. One is that the myopia epidemic in Asia, East Asia and Southeast Asia, it preceded the development or the release of tablets. The iPhone was released in 2008. And even the personal computer came really after the children in places like Hong Kong were developing high levels or high prevalence of myopia. The second thing is there's very, very little difference that screen time or any sort of read-in will affect the rate of progression, okay? There's a strong evidence that outdoor activity will lower the incidence of myopia, but outdoor activity doesn't seem to have much effect on the progression of myopia. Having said that, myopia does seem to have a seasonal pattern and progresses more in the winter and less in the summer. So that's, you might take that as indirect evidence for an environmental role.
Okay, I think we have to move on, right, Ramesh?
I think we have to move on. Over to you, Ken.
Okay, so Mark, these questions are to you, but rather than take them individually, I'd like you to try and sort of lump them in together if you can. And the questions are, what is the effect of orthokeratology on axial length? From what age can we use orthokeratology? When do we stop orthokeratology? How do we address the issues of cost in low-income countries? How do we manage hygiene issues in low-income countries? And then the last two questions we'll take slightly separately about, you know, can you use it in pseudophakic children or glaucomatous children? And can we combine it with atropine?
So, okay, I'll try and be succinct. So first of all, the if you look again at meta-analyses of orthokeratology, the results are remarkably consistent across populations, lens designs, even sort of modest variations in the age of the children. Orthokeratology will slow axial elongation by about 0.25 millimeters over 2 years. And longer term, you get greater benefit. Now, that corresponds to probably about 0.6 diopters slowing. So that's very competitive compared to other options. What age? It depends on the child and the parents. A lot of parents like Ortho-K for their children because they can put the lenses in themselves at night and take them out in the morning. The kid doesn't have to go to school wearing soft lenses. And this is very good from the point of view of compliance. Typically, children probably can't handle their own contact lenses until, on average, they're at least 7 years of age. But it varies, of course, with the kid. When do we stop? Well, like most myopia, we know will, on average, stabilize at 15, but there's a huge variation. We know from the COMET study that 25% of children will still be progressing at the age of 18. So when do we stop? When you've been measuring axial length and it's stopped increasing. That's the time you can stop. Cost and availability, I think this applies to really any modality, whether it's the new generation spectacle lenses, Ortho-K, soft lenses. Ortho-K in some respects is more cost effective than other options because the lenses can frequently last for a year or two compared to soft lenses, which are obviously going through either on a daily or a monthly basis. And hygiene issues, those are always going to be an issue regardless of where you are in the world. We know that with any contact lenses, the storage and the handling and the case are the sort of the pressure points when it comes to risk of infection. So it's something that, again, what are the child's habits? Okay. Do they come in with dirty fingernails and whatever? Do the parents come in picking their nose and with dirty fingernails? Those are probably bad signs. So I'll stop there and let other people chime in, and you can correct me on anything I said wrong there, Ken.
No, I'm not correcting you. I was going to say, one of the things I ask parents is, how tidy is the child's bedroom? If the child can't make their bed and can't keep the floor clean and have everything tidy, that's an indication to me that they have no self-discipline. And then I worry about
do they clean their teeth?
Yeah, and do they clean their teeth? Right, let's open it up. Anyone want to add to anything that Mark has said there?
Like in Singapore, yeah, we agree. And in Singapore, the kids who do a lot of water sports like water polo, synchronized swimming, so we tend to they tend to find Ortho-K very good because they can't have glasses or anything during the day. Yeah, the water sports people. Yeah.
And so, can I ask the whole panel? Does Ortho-K work essentially by dealing with that peripheral hyperopic defocus? Does it have an effect on that?
Yes.
Yeah. Okay, good. We're all agreed on that. So that's good. Anybody, Cheryl, Carly, Ramesh, Ian, anything to add to that before we move on?
I just had one quick question, Ken, to add to this. What's the limit where we can treat with Ortho-K? Any myopia?
Certainly up to 4 diopters comfortably, and maybe up to 6 diopters. But even in higher myopia, there's evidence that if you partially correct the myopia with Ortho-K, and the kid wears spectacles during the day to correct, say, a residual couple of diopters, that's still effective. So there's certainly the limit. But of course, from a theoretical point of view, the more myopia you correct, the more epithelium you compress, potentially the greater the insult to the corner, if you like. Having said that, the danger, the danger cases for Ortho-K are actually the low myopes, where you have less variation in corneal power produced by the lens, so you have less therapeutic plus, if you like, in the periphery. So there's a number of papers showing that Ortho-K is less effective in the low myopes. So
I think orthokeratology also can correct up to 2 diopters or 1 3/4 diopters of astigmatism as well, can't it?
well, yes and no. The lenses in the US are approved for up to 1.5 diopters of astigmatism. They will probably partially correct that corneal astigmatism. But again, that's depends probably on the individual child.
So do any of you combine orthokeratology with atropine? Does anybody do that?
There are some patients who have requested for that. So it's like I said, the water spots kids. So then we would they are on very low dose atropine, 0.01, and then they add ortho-K.
And do you put the atropine in the morning or at night when you put the ortho-K in?
They put it at night when they fit at night.
Anybody else got any
swimming and all that?
Anybody else
no
got
experience, but I'll speak to the evidence. And yes, add in atropine to ortho-K will increase the efficacy, particularly in the low myopes, because they're the ones that don't respond to ortho-K as well. The question, of course, is what concentration? 0.01%, 0.05%. That's another consideration. Most of my myopia management colleagues in the US and Canada, they tend to start children on optical methods, be it soft lenses, ortho-K spectacles. And if they're not getting enough slowing of progression, they add atropine.
Okay, so just very quickly. So the pseudophakic children or the glaucomatous children, as far as for glaucomatous children, control the pressure. I have not, in my experience, I actually haven't ever tried it, but I've never thought that in the glaucomatous children where the sclera has been stretched, that there's going to be an effect of any sort of myopia control, but maybe I'm being too conservative. Anybody have glaucomatous children? I mean, the pseudophakic children are a different story.
Yeah, well, would you prescribe atropine for a glaucomatous child?
I haven't. I have not even considered it. But is that because I'm too conservative? I just don't know that it would work. I don't know.
Going back to Ian's sort of earlier comment, I think, or maybe it was yours, Ken, I apologize. You know, if you've got a child with glaucoma, pseudophakic, early onset or congenital high levels of myopia, they're not like the children who've participated in most of these clinical trials we will talk about. They're a different beast, first of all, and you have to be, I would say, very cautious about your expectations, because this is this is not a horse, this is a zebra.
Absolutely.
Or say Ken, a zebra.
Yeah, no, I agree. I agree with you. And I think when you have myopia associated with retinal diseases, that's even more important, because we do not know at the moment at what level the atropine is working. And if you have an abnormal retina, you could be making things worse. That's my worry. Anybody got a counter argument to that or a counter opinion? Do we all agree? What a lovely panel.
Could I just make a quick comment? There must be a lot of information on these kids in the offices of pediatric ophthalmologists around the world. And I think a project to actually pull it together, we're never going to get at these sorts of kids in an epidemiological study.
No, you're
They're
right.
too rare. But
totally
clinical records are a really invaluable source.
And
there's just in that regard, there's a whole set of International Myopia Institute papers coming out in a few months. And one of those papers specifically deals with the zebra myopia,
yes.
The unusual myopia, the young kids, and has some really good talking points in there. Ken, you might have even been involved in that.
Yeah, well, Ian Flitcroft was the lead author on that, and I think it's a very well put together study.
It'll be a good read when it comes out.
Ramesh, all yours. We're running a little late, but it's all good stuff.
Let's move on. It's a similar questions. What's the difference between ortho-K and soft contact lenses?
Well, obviously, soft lenses you wear during the day, ortho-K you wear at night. but the ones that are effective are the ones that manipulate the peripheral retinal defocus. And Ortho-K flattens the central cornea, leaves the periphery intact, so you get plus power in the retina, in the peripheral retina. And the dual focus designs, some of the EDOF designs, they're working on the same principle.
Yeah, continuing with that, how and when do we prescribe soft contact lenses?
Cheryl.
Practice. Sure.
So anybody of the panel, how do you decide which one to prescribe? Shall we?
Older kids who are very conscious about wearing glasses, and they don't like the MiSight contact lenses. The older kids, not too much astigmatism, they do quite well with the soft contact lenses.
Any other panel members have any other suggestions or advice? Okay, if not, we can move on.
I have a question. How do you decide Ortho-K or soft? How do you make that decision? I mean, Xiaowei gave a great example. If you've got somebody who's doing a lot of water sports and they want to use a contact lens, that's orthokeratology, done. But otherwise, how do you decide?
I think, as you said, lifestyle.
We discuss with the parents. So the water spots is water spots, and the other thing is the in Singapore they study a lot. Some of the older kids, they don't sleep enough, so that there's no time. The Ortho-K doesn't work too well for them because they're not sleeping enough. They have a lot of work. I know you may not find that in the rest of the world, but yes, we have that problem. So
you guys, you're working too hard. All right.
Yeah. So they can't. So these kids, yes, we have that.
So wait a minute. How many hours of orthokeratology do you need for it to be effective? I mean, is 4 hours enough? Is 6 hours? 8 hours?
Good question.
We don't know.
No, I mean, I think it's a difficult study to do because, you don't want to be depriving people of sleep.
Wake up the kids.
Okay, all right, we're going to move on. I'm being told that we're running too far behind. Okay, these questions I think are going to Carly. Here we go. Carly,
okay.
Does wearing a correct prescription upon developing myopia have an effect on progression? Does not wearing it increase the rate of progression? Is the quality of vision good with new defocus technology spectacles? How about those? Take those first for me.
Okay, right, thank you. Yeah, so the first one is that wearing a prescription definitely will promote myopia progression. There have been a paper suggesting that the meniscus of the single vision lenses actually produce a good focus on the fovea, but it also produce peripheral hyperopic defocus and therefore promote myopia progression. And the second is, does not wearing it increase the rate of progression? There are also 2 studies trying to undercorrect the children who has myopia and found out that undercorrection actually promote myopia progression. So I think in many paper, many literature review already suggested undercorrection is not an option of intervention. So is the quality of vision good with the new defocus technology? First of all, the defocus technology is either 2 foci or multiple foci. So it's a sharing of different focal points in the same visual field. Definitely, there will be some compromise. But most of the studies in 2 years RCTs or even longer follow-up show that despite there is this specific design, but visual acuity, contrast, and also stereo acuity, binocular vision were not really affected. And there was a latest paper looking at the visual field, sensory visual field, also show no differences comparing to single vision lenses.
And should we put all myopic children in controlled spectacles regardless of progression?
Yes.
Yeah. So a year ago, I would say yes. A year ago, I would say yes, but now I don't. The reason is because we have recently published a couple of papers on the peripheral refraction, relative peripheral refraction. And we found that the younger children, some of them had myopic peripheral refraction. And if they already have myopic peripheral refraction and we add on the extra myopic defocus, it doesn't seem to work very well. So that's why I think it's not for everyone, but if we look at their peripheral retinal profile, and they are already on the hyperopic side of refraction, then we can definitely go for the this type of intervention. But if they are myopic peripheral refraction, we have to observe.
Okay, there's a bit of controversy here. Mark and Ian, you were jumping in. What were you saying?
I think
Not sure.
all things being equal, there's no excuse for a young myopic child to be prescribed regular spectacles when there are very effective spectacle options available.
Well, I was talking about intervention spectacles. So yeah, so no difference, no contradiction.
No, absolutely. No, we're allowed to disagree. So the issue is, how do you measure peripheral refraction? What do you do? And this is a knowledge gap for me.
Yes, usually.
I don't think measuring peripheral refraction is useful in the management of an individual child. It may give you indication of what happens in a cohort of patients in a clinical trial, but it's not necessarily useful in predicting what's going to happen on an individual child's case. They've got some very comprehensive data on that from the Blink study, 3-year clinical trial, and it doesn't seem to have any predictive value on an individual child.
Yeah, it is true that there are so much variation in the peripheral refraction, but I hope that we have better instrument that we can have a more accurate assessment on this.
So I'm just going to go right across the panel because we're running out of time. Ramesh, if you had access to these new technology spectacle lenses, would you give those first before atropine, or what would you do?
Yeah, that's what we do it in our center in Nelly Prasad, that we measure peripheral refraction, because that's where we have an opportunity to check in that particular child whether there is a relative peripheral hyperopia or relative peripheral myopia.
Okay,
so
Cheryl?
once you know that data, I will try to give that kind of customized approach to that child.
Okay, Cheryl?
So I don't have the equipment to be able to measure peripheral myopic defocus, but I do suggest using peripheral defocus spectacles as my first optical treatment before other methods.
Okay, Xiaowei?
It depends on the child and after discussion, because in my experience, the younger kids, they tell me it's very difficult to use the peripheral defocus. They find that it's a bit blur. They somehow don't like it. I have had some complaints. The older kids, it's one of the discussion. So the older kids take it quite well.
So Ian, do you have an opinion on this?
Well, it just seems to me as a matter of principle, the least invasive option has to be the safest. And I don't think you can get less invasive than spectacles.
So are we all agreed that there are no side effects that we're aware of at the moment of peripheral defocus with spectacles? Yes?
Yeah, it's just the cost. It just costs that's a little bit higher than the
cost is a huge side effect.
The cost is an issue.
All right, I'm going to pass it on to Ramesh now.
Yeah, thanks, Ken. This question's on pharmacological pupil modulation. This is for Xiaowei.
Okay.
If you could see the questions, I'm going to combine make it into two groups.
Okay.
First one is, would you recommend atropine treatment even in the absence of myopia progression? What age can we start the atropine treatment? And can we combine it with glasses?
Okay, so
17 glasses. So these two questions, and then we'll go to the other questions.
Okay, so like I said, even if it's the first visit, they give a history of that it was okay, then that to me counts as progression. So I don't really see that in the absence of that. That's really rare that you don't have that. And I always use a chart where, you know, I show them the population charts of the myopia that predicts, you know, there are these charts around that you can show them that's at risk of developing high myopia later on. So that's how you can start. So you don't really need to wait for 2 visits in that sense. At what age? My own son, I started at 3. When he was 3, I started atropine for him. When he was 3. So to me, it's really that you can start 3, 4, like kindergarten age. And yes, we do combine with glasses. They do combine with glasses. The lower concentration they can combine with the defocus glasses, the new glasses. The higher concentration, because they need photochromatic lenses, that's why they can't have all the new peripheral defocus glasses. Yeah. And next question, is there influence on the color of iris pigmentation? Actually, the latest, I think the Western Australian studies found that the atropine actually works better in the Caucasian kids with the lighter iris. For me, I think that there is an influence because actually it works better for these kids, but they also have more side effects. So if you start a higher concentration on a kid with very light color iris, the pupil is really very dilated, and the parents and kids may not like it, and they get a lot more glare. So it's a double-edged thing. I think it works better, but it also has more side effects. So yeah.
When you say this, you start this treatment, Shoei, what's the percentage of this atropine you start with? You know, there is a difference between the pigmentation. So that's an important aspect.
Okay, so in my practice, because I see a lot of Caucasian kids as well, so thankfully a lot of them have lower myopia. They are the older kids, lower myopia. So there is still a role of the lower dose. You can even do 0.01. I have 0.01, 0.025. And the Asian kids tend to be the younger ones, the more rapid progressor. I start on 0.05.
Okay. At this point of time, any other suggestions or answers from the other panel members? We'll start with Carly.
Oh, sorry.
Do you have anything? No. Cheryl?
So
Mark?
unless the kid is younger and high myopia and really shows a rapid progression, I generally don't start atropine until they are about the age of 6. Because I do tell parents that usually we do have to continue the treatment until the age where they emmetropize. So if we start younger, the total duration of treatment may be really long, and we don't really know what is the long-term effect of using like 10 years of atropine because of the pupil dilation, the effect of UV, whether they really can get cataracts or even age-related macular problems at an earlier age. So I think something that we do have to discuss with the parents, but I generally try to push back starting treatment until they are a little bit older.
Yeah, can I just say something? Maybe it's the population I look after in Pittsburgh, because we are special in Pittsburgh, but I don't see pupil dilation. 0.01%, I just have not seen pupil dilation. Now, if they've got blue eyes and somebody started them on 0.05, which happens in the community, then they get problems. They get dilation and they have accommodative effect, but not 0.01. I've just not seen dilation, especially in the dark eyes.
Yeah, that is why the 0.01, that's why for Caucasian kids, they can do 0.01 quite well. They tolerate it quite well. But 0.05, the pupils are dilated for the light iris.
But in Asian eyes or subcontinent Indian eyes, do people see dilation with 0.01 or 0.025?
Minimal, but there is still dilation.
There is.
Not a lot, but there is.
Even on 0.01.
It depends on the child as well, yeah. So they need photochromatic lenses.
So I haven't had anybody at 0.01. I've not had anybody complain about light being a problem. As I said, Pittsburgh is special.
But we are quite sunny here, yeah.
That's true. We're not very sunny. We're very gray.
Yeah.
Maybe there's something wrong with your formulation.
That could be, but it works.
Okay. So we don't have the compound. That's another whole talk altogether. There's a lot of issues if you have the compound. I don't know what temperature and what's your excipient, and so here we don't do compounding. So we're quite okay in Singapore. It becomes commercially available.
So Ramesh, that comes to the point about certain atropine concentration not available in certain countries. Should we dilute with artificial tears or say? I mean, I think you should get a compounding pharmacy to do that. That's the sort of next best. The best is, have a commercially available product. But I'm interested, Ramesh, do you see dilation in India?
Yeah, we do see. When I say yes, it's pretty rare. Some patients complain of reading problem, even with 0.01%. I'm not talking about 0.05, even with 0.01. But that's not a very, very negligible population, I must say. Very, very less, even with 0.01%. But with the 0.05%, it's not available currently in India. We dilute and give it to the patients. And I don't know, there is a part of the question is how to lower the dose, and do we give any other frequency other than OD? Any of the panelists give it BD if there is a progression, because that's a related question there.
I think
Make it twice a day.
There's many ways of doing it, so it really depends on what you have available. So I will discuss with the parents, because like I said, I have 0.01, 0.025, 0.05, and so forth. So sometimes when because they have two kids on 0.01, so the one that needs more, then they would use it twice or 2 drops. You know what I mean? Like the one that actually needs a little bit higher, they would use that. So you can do that, and the reverse is also true. Like, let's say a child, it's been on 1% and you're trying to tail down, you can do it. You can decrease the frequency. You don't do it every night anymore. You do it, 2 or 3 times a week, that sort of thing. So it can vary. So you can vary the frequency quite.
Other related question is, do you use cycloplegic agent if atropine is not available?
No,
May not be
I mean,
in Singapore, I guess. So,
yeah, it's totally different, right? I mean, I don't think the anti-myopia effect is it's different from its cycloplegic effect. So you can't just replace like that.
Yeah.
So I have a question. So how do you monitor compliance if it is up to the child, to use how many drops per day?
Okay, so the best would be because we have both preserved and non-preserved. So the preservative-free option is very good because I make them throw away the valves, right? So you can see in 1 month how many valves they have left, and you know how many times they use. Okay. So that's how we tell. But of course, the bottle type, you can't really tell. Yeah.
Yeah, because of the time factor, I think we should move on. I would ask the last question here. This is very relevant, I think. What's the oldest age you start low-dose atropine? Showing and other panel members. Oldest age.
If they are progressing, so even if, like if they're progressing, then there's with axial length elongations too, I would also start. I think the oldest I start maybe 11 by the time I saw the child. Okay.
Ken, do you have any comments on that?
I was just going to say I don't treat myopic progression in children with ROP. That myopia is almost like it happens because of the disease, like FEVR. I don't treat that, again, for the same reason. I'm worried about the effect of the treatment on the eye, and especially since the peripheral retina is being affected anyway. So does anybody disagree with that?
Yeah, we agree, and also I think the myopia in ROP kids is totally different. It's due to differences in the anterior segment, not so much the posterior segment. So the axial lengths are also different. So yeah, I don't treat that. Yeah. The myopia in ROP.
Shall we move on?
Yeah, we'll go ahead.
Okay. So this last question's for Cheryl. How to best counsel parents of pre-myopic children to start the myopia prevention modalities? What are your management strategies? What's the best way to monitor myopia progression other than refractive error? How do we know that the axial length is physiological or pathological? All yours. Lots of questions.
Yeah, so basically, I think for children who have a risk of becoming myopic, especially your myopic parents, family history of strong myopia, I think educating the parents is important, that actually lifestyle modifications from the time when the child is born try to limit the screen time, especially in those who are less than 2, maybe no screen time, and then also reduce the intensity of near work and increasing the outdoor time, and bring this into their lifestyle so that children enjoy having outdoor time since they are young. And I think it's important for them to send their children for regular vision screening from the age of about 3 onwards. And in my practice, I usually would measure axial length other than refractive error, and I usually measure this every 4 to 6 months together with the changes in the refractive error. So how do I know whether the change in the axial length is age-related, physiological, or pathological? So if we look at literature, we do know the mean axial lengths of children at different age groups, usually mainly measured using A-scan ultrasonography, but more recently, I think the studies have tried to trend axial length elongation in school children with optical biometry. So from these, we can sort of get an idea of maybe what is the age-matched normal, and then we can sort of deduce if the change in axial length pertaining to a particular child is actually age-related, physiological, or pathological. But I think we do need more studies, especially maybe a population match study to be conducted and published, so we know what is actually the normal range and what is the normal trend in each population, because as you can see, it's depends on their environment as well as their genetics as well.
That's great. So are there any cheap or cost-effective instruments to do biometry? I don't know any.
Yeah, I think optical biometry is still the best because it's non-contact, but it requires a certain amount of cooperation from the children. A-scan ultrasonography is cheaper, but not every child would be willing to use an A-scan, have the probe touch their corneas, and there's always indentation.
I mean, you know, I'm opening this up to the whole panel. I mean, I guess the big question here really is, you know, if some of these machines are really expensive, and some of the companies have brought out these myopia control machines that do biometry, that do refraction. But I mean, has anybody got any ideas of any innovative or startup companies? Maybe we should all start one.
There's at least one company out there developing low-cost biometry devices, you know, for this market, you know, targeting, you know, $10,000 or less. So it would be a similar price to an A-scan ultrasound, but have a much greater level of precision. So there may be stuff coming.
That's great. And the other question here is the question, you know, what could you do to prevent the evolution of myopia in children younger than 3 with myopia greater than -6? That's the first question. Make sure you're not dealing with a genetic condition. I would definitely make sure you're not dealing with a genetic condition. And what's the best intervention for myopic progression in pseudophakic children? Honestly, I don't know. And it's a different, I don't think it's the same condition as the progressive myopia of childhood. So please, 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 if you're going to treat these children, the ones who are pseudophakic or have a retinal problem or have high myopia at a very young age, please be clear in your mind that the evidence that we have at the moment does not relate or pertain to them. That's really important. Would everybody agree on that?
Yep.
Okay. Yeah. So anybody got any differences or any other opinions about the pre-myopic child? Has anybody started a child who is, let's say, 4 years old, -1/2, both parents are over -10?
Yeah.
Okay.
My son started at 3.
All right. That's fine.
I started him on 3. Yeah. He's,
okay.
And he's a low myop now. Huh?
Atropine?
Okay. Yes, I did atropine. And this was like nearly 20 years ago. We didn't have the low concentration. I actually gave him 1%.
Okay.
Yeah, he wore sunglasses to school. Yeah.
Okay, last question. Is red light therapy useful?
Yeah.
Well, yeah. It clearly works. I think the issue, like with anything new, is safety.
Agreed.
So far, what I've seen is pretty good, but it is early days.
Are you agreed on that?
Yeah, I mean, it seems to be taking off like wildfire in East Asia, but you know, the issues, is this a therapeutic effect or a phototoxic effect? What are the light levels? You know, how can we get sort of such a remarkable result treating a child for 3 minutes twice a day? You know, well, how do we, so why not 10 minutes or why not a minute? There's a lot of unanswered questions here.
So it remains, honestly, this has been an amazing session. Ramesh, I think you'll agree that, you know, we've had discussions, we've discussed, it sounds to me like there's a pattern forming here, right? Behavioral interventions, and then optical or atropine, you have to decide, you can do the two together. It was a great discussion about orthokeratology versus soft contact lenses. I learned a lot about, you know, I hadn't thought about lifestyle. I'm going to introduce that in my discussions before we decide which way to go. We've certainly discussed what we, you know, which children we should be cautious about. We've talked about digital screens. I hope everybody listening has a kind of a clearer idea of how they might want to approach this. So I'm going to do audience response questions. So just to let everybody know, we had people from all over the world, even Australia. Ian, you must be very popular that people were staying up to listen to you in Australia. And I wanted to know that 76% of the listening audience treat 11 or more patients with myopia a week, which I think is phenomenal. That's a much bigger number. So the ARS, how significantly do you believe what you have learned today has improved your ability to manage myopia progression in pediatric patients? A, B, C, or D? If you could answer that, and somebody will give me the answer, hopefully. Ramesh, I'm going to ask you to wrap up while we get some responses from the last ARS.
Yeah, Ken. I'd like to thank everyone, all the viewers who joined today, and all the viewers who asked this question so that we can discuss more. My special thanks to all the panelists who have joined this. And thank you to my co-moderator, Ken, and also the whole WSPOS admin team, Maria, Daniel, and Akila, who has worked on the background and to make this symposium and the webinar, the question and answer webinar, very, very successful. And thanks to all of those who joined from different parts of the world. Thank you so much.
So I'm just going to add a couple of things. I'm being told right now that we don't think that any society has ever done a webinar dedicated to the questions that were raised in a webinar program or education program. I don't know if that's true or not, but that's thanks to you guys listening to do that. And I think it's been really useful. I have to thank our supporters, Essilor, Luxottica, gold level supporter, Hoya, silver level supporter, and CooperVision, bronze level supporter for this IME. I don't have any responses from the ARS at the moment. I'm going to try and give us a few more minutes. We're only 2 minutes over. So if you have one last pearl to give everybody, I'm going to start with Ian. What's your pearl, Ian?
Concentrate on the educational pathway the kid's undergoing. That's really the crucial thing in terms of environmental inputs.
Xiaowei?
There is our field is always evolving. There's a lot of new things in myopia management, and I think we should all be very open to new ideas and combination therapy.
Carly?
Yeah, educations to parents and young children, especially young children, so they understand what the impact of myopia is.
Mark?
Really building off what Ian said, we published a paper last year or the end of last year that says an ounce of prevention is worth a pound of cure. We have the greatest potential to make a large amount of difference by myopia prevention and delaying its onset. And that's where we should focus our efforts. And even if you're not interested in prescribing spectacles and contact lenses and atropine, you can make a huge difference there.
Thank you. Cheryl?
Yeah, so there's a lot of different treatment intervention and modalities. I think a lot of it involves discussion with parents and the child and modifying it according to their lifestyle.
Okay, Ramesh, I'm going to give you the last word, but I'm going to just tell everybody the answers to the last ARS. 25% that it's very significantly changed their ability to manage myopia progression in children. 46% significantly, 24% somewhat significantly, and 5% are saying, no, 4% are saying there's no change. Clearly, Mark Bullimon's been on the ARS answering that question. On that note, Ramesh, I'm going to leave it to you to close out.
Yeah. Thanks, Ken. I think I must say that there are 16 to 20 approaches for myopia. I think people around the world, if they can join together and make it more customized for people, that will help these myopic progressors. And most importantly, lot of resources has to go towards preventing myopia. You know, we are looking at 10% of the people who are progressing. We are concentrating, but at the same time, we need to see the other kids are okay, what we can do to them so that they don't progress. Thank you so much, everyone.
Have a great day wherever you are in the world. Thank you so much for being with us.
Have a good sleep, Ian.
Yeah, I'm off to bed.
Thank you.
Bye-bye.
Thank you. Bye-bye.